Hello and welcome to the WPS webinar on Skilled Nursing Facility MDS Section I, Issues and Findings. My name is Mary Sue Gardner and I'm a registered nurse on the Provider Outreach and Education team. And I'm joined today by Jennifer and Rachel, who are the other nurses on the Outreach and Education team, as well as some representatives from Medical Review, should we need them to help with any of the question and answer portion of today's call. In many nursing homes, there is a gap between the documentation in the medical record and the diagnoses that are coded on the MDS. And that gap is the physician-documented diagnoses. For example, many residents are at risk for malnutrition. However, it can't be assumed from other clinicians' documentation. The diagnosis has to be written by the physician. We're going to look at for backup information to support that, but that diagnosis has to be documented by the actual physician. So today we're going to discuss Section I of the MDS and some tips for helping your physicians capture active diagnoses. The items in this section are intended to code diseases that have a direct relationship to the resident's current functional status, as well as cognitive status, mood or behavior status, medical treatments, nursing monitoring, or risk of death. One of the important functions of the MDS assessment is to generate an updated, accurate picture of the resident's current health status. So as we move on your screen and in your slide deck, if you're following along with the slide deck, is our disclaimer. And basically, our disclaimer says we prepared this information as a tool to assist you as our provider community. But know that the Medicare laws, rules, and regulations often change. So the information we're providing today is as current as the laws, rules, and regulations are as they stand today. If CMS decides to change those laws, rules, and regulations tomorrow, it's your responsibility as a Medicare provider to make sure you're following the current laws, rules, and regulations that are in place on your dates of service. Now, we're going to provide responses to questions based on the facts given and the laws, rules, and regulations as they stand today. CMS also prohibits you from recording this presentation for profit-making purposes. And since we don't know why you would be recording or screenshotting any of the presentation, and we can't prove it's not for profit-making purposes, we ask that if you are doing that, for you to please stop doing that. But we are recording it for you, and pending the outcome, it will be available for you to view later on our YouTube page as an encore of today's event. On the slide, on the screen are some acronyms that are common in skilled nursing facility and the MDS, and should I happen to use one of these acronyms during the course of this webinar and you don't know what it means, you can always just refer back to this page. My objective for today is that you learn about the identified issues in Section I of the MDS that can lead to a skilled nursing facility claim being recoded into a different PDPM payment category. We're going to achieve this today by reviewing the Medicare drivers of payment for Section I. We're going to highlight the importance of only capturing physician-documented active diagnoses and what active diagnoses means. And we're going to go over some tips to help your physicians capture those active diagnoses. So just a little bit about Section I. Section I is the active diagnoses section of the MDS. It must be documented by the physician or the physician extender who has direct knowledge of the case. Accuracy is critical because it plays a vital role in PDPM reimbursement. So as we move on and show you the various components of Section I, we're going to discuss their importance as well. So let's talk about the importance of capturing the diagnoses accurately. Ensuring that Section I is accurate and up to date has always been important. Active diseases and infections have a direct relationship, as we said before, on the resident's current functional status, cognitive status, mood or behavior status, medical treatments, nursing monitoring, or even risk of death. The direct relationship means that Section I affects your care planning, patient's quality of life, and even multiple quality measures. So accuracy has become even more critical under the Medicare Part A PDPM model, or the patient-driven payment model. And it's because of the following reasons. The ICD-10 codes captured in items I0020B, that's the resident's primary medical condition. Those determine the resident's default Medicare primary diagnoses and the clinical category for PT, OT, SLP components. The specificity of the diagnosis code can make the difference between a code assignment that maps correctly into PDPM versus one that is designated as a return to provider or rejected diagnosis. So certain ICD-10 codes entered in Section I-800 or I-8000, which is your additional active diagnoses area, those count as comorbidities for the speech-language pathology component or for the non-therapy ancillary component. There are certain diagnoses captured by Section I checkboxes that can affect the non-therapy ancillary or NTA component, the SLP or speech-language component, and even the nursing component. So for example, I-5200, which is multiple sclerosis or MS, can impact PDPM case mix classification in both the non-therapy ancillary and the nursing components. So there's a little more information. The non-therapy ancillary could be scored with the 2-point, and the nursing special care low qualifier with the nursing function of less than 11. So those can all be affected. If you want to learn more about the PDPM classification worksheet for SNFs, you can go to Chapter 6 of the Medicare SNF PPS of the RAI manual and find that information and the mapping tools. I was trying to quick pop out, excuse my stutter for just a second. I was trying to pop out the hyperlink. There we go. So I can post that in the chat for that mapping for you. Okay. So as we move on, let's talk about some tips to help accurately capture diagnoses. A physician query is a communication tool that's long been used by coders and clinical documentation staff for improvement in other healthcare settings. And it's used as a request to the physician to clarify patient diagnoses or procedures. So a query can be a really powerful method of clarifying documentation in the medical record and really achieving accurate ICD-10 code assignments in nursing homes. It can also be used to confirm diagnoses, to identify additional diagnoses, and for your checkbox items in Section I. So it's important that the nurse assessment coordinators and other MDS assessors not assume a diagnosis from something the physician has written if it's not clear. You need to query the physician because it's not up to the coder to try to figure out what the diagnosis could have been or should have been. So failing to query your physician puts you at a significant risk for capturing something incorrectly and requesting incorrect payment to the Medicare system. So facilities that are using nursing assessment coordinators should work with your medical staff, your medical records staff, or medical records consultants, as well as your medical director, to develop some sort of effective physician query process that really can be used to add a new diagnosis or clarify an existing diagnosis for greater specificity. You may want to define a query procedure from start to finish. And in that include who will make the queries and how the form will be transmitted to that physician, whether it's via fax, whether it's by any other HIPAA compliant method, whatever you're going to use. But I do highly suggest that you write out some sort of method and how you're going to do that. So here's some examples when a query may be important. These are some common situations in which queries are necessary to include. So the first one is a culture lab report indicates an infectious organism, and there's no documentation substantiating the significance of the organism or the disease process for this. So you would want to query the physician to figure out what they want for accurate diagnosis of this. Another, the resident has a diagnosis of urosepsis, which is not specific and does not support coding an actual UTI or sepsis. So again, querying the physician as to letting them know this doesn't have a diagnosis category, what do they want to use, is a good way of getting that. So others, the physician has documented a diagnosis of anemia without etiology. The resident has a dietitian documented BMI or body mass index of greater than 40 without having a diagnosis of being overweight or obesity or morbid obesity. And then the others, the resident has a dietary assessment of low body weight and poor intake without a diagnosis of malnutrition or risk for malnutrition. And finally, a negative outcome occurred, but there's no clear indication in the medical record whether the outcome was a complication of care. So these are all examples of cases that we see in medical records quite often that are opportunities for you to provide your physician with a physician query and make sure you are capturing the most accurate diagnosis. So as we move on, let's talk about this sample, and this will maybe help drive it home. So this resident has a documented diagnosis of urosepsis. They also have a temperature of 102 degrees Fahrenheit. They're confused and they have low blood pressure. Per ICD-10 coding guidelines, urosepsis is a non-specific term. So it's not to be considered synonymous with sepsis. it has no default code in the alphabetic index. So we're going to let our physician know this information and say, based on your clinical judgment, would you add any of the following diagnoses to the resident's clinical record? So is it a UTI, yes or no? Is it sepsis, yes or no? Is it something else? And you can give them a place to fill this in. Is it clinically undetermined? And then you would also sign and date those. So this is just an example of a query statement that you could provide to your physicians to help clarify that information. Now, as we move on your screen and in your slide deck, we've provided you a link to the Briggs Sample MDS 3.0. And I like to use this sample, and I used it in the general overall PDPM education, and we used it last week when we talked about section GG. And I just like to use this because it makes it simple to see what areas affect Medicare payment. I'm going to use the link on the slide deck, and I'm going to go out and show you their sample. Now, remember, this is a sample, and it's marked as such. I'm not promoting it. I have no vested interest in this company, etc. I just like the way they have included the Medicare indicators. Give me just a second to bring this up. And Jennifer, can you verify if you are seeing the Briggs sample on your screen?
Yes, I am.
Perfect, thank you. Okay, so a few things to start with. On this first page, you're gonna notice at the top, there's like a green money bag and a green hexagon at the top of the screen. So the green money bag indicates that this section affects PDPM payment, and the general green and green hexagon indicates SNF quality reporting program measures. So I'm going to scroll down to section I of this. Give me just a second, which I know on this sample starts on page 22. Okay, so section I, as I've said, is a big one. And remember, for today's purpose, we're going to focus on those drivers in this section. So again, section I is on active diagnoses. As you can see here in section I0020, primary medical condition category, you can see all of these are marked with a green money bag and green hexagons. That means these are main drivers. So this is your starting point, and this is where you choose the primary medical condition category that best describes the reason for admission. So as we scroll down to the next section, then we're going to start seeing in this next section are the active diagnoses in the last 7 days. So this is section I0100. So things like an active diagnosis of ulcerative colitis, Crohn's disease, inflammatory bowel disease. You can see all these in green really affect your Medicare payment. These are the big ones. So we've got multiple drug-resistant organisms, pneumonia, sepsis, wound infection, diabetes. Down here under the neurological, we have quite a few conditions that are affected under the neurological, as well as TBIs or traumatic brain injuries, malnutrition, asthma, COPD, other lung diseases, and respiratory failure. So those are some of the, excuse me, active diagnoses that you can see here that affect specifically your Medicare payment drivers. All right. And again, those are diagnoses that have occurred in the last 7 days that are going to affect that reimbursement. All right. So that also means that you mark any of these diagnoses, we are really going to double and triple check and verify upon review that they are actually active within the last 7 days. Now remember, active diagnoses means physician documented diagnoses in the last 60 days that have a direct relationship on the current functional status, cognitive status, mood or behavior, medical treatments, nursing monitoring, or risk for death during the 7-day look-back period. So they had to have been identified in the last 60 days and have an effect on one of those in the 7-day look-back period. Remember, if a disease or a condition is not specifically listed, enter the disease and ICD-10 code in the I-800 area. So additional, or I-8000 area, I'm sorry, and that's your additional diagnoses section. So let's move back to the slide deck. And we're going to talk more about those active diagnoses. So look at that Briggs sample. We kind of discussed these sections, but I just want to highlight them again. So the I-020 is a resident's primary medical condition category. So that's the reason for the Part A stay. Then you proceed to the I-00200B and you enter the ICD-10 code for that condition. When an acute condition represents the patient's primary reason for the resident's SNF stay, it can be coded in the I-0020B. However, if it is it's more common that the resident presents to the SNF for care related to an after effect of a disease or a condition or an injury. So therefore, subsequent encounter or sequela codes really are what should be used. So again, you can refer to the RAI manual for additional information about those codes. So let's go on and look at some examples of primary medical conditions. The rationale behind this, the physician's history and physical document the diagnosis of stroke as the reason for Miss K here for her admission. And so we have Miss K, a 67-year-old female with a history of Alzheimer's, dementia, and diabetes, who was admitted to the skilled nursing facility after a stroke. The diagnosis of stroke, as well as a history of Alzheimer's, dementia, and diabetes, is documented in Mrs. K's history by the admitting physician. So the first identified diagnoses, the disease conditions in this section that require physician documented diagnoses, or by the nurse practitioner, physician assistant, or clinical nurse specialist, if it's allowable in your state, for this to be identified in the last 60 days. So medical record sources for the physician diagnoses include progress notes, the most recent history and physical, looked at transfer documents, discharge summaries, a list of diagnoses and problems, and any other resources that are available. And those are the types of things that we're going to look through to verify this. If the diagnosis or problem list is used, only diagnoses that are confirmed by the physician should be entered. So although open communication regarding diagnostic information between the physician and other members of the interdisciplinary team is important, it's also essential that the diagnoses communicated verbally be documented in the medical record by the physician to ensure follow-up. Diagnosis information, including past history obtained from family members and close contacts, must also be documented in the medical record by the physician to ensure validity and for follow-up purposes. So the second is the diagnosis status. That's the active or inactive. So determine whether the diagnoses are active would be done by once a diagnosis is identified and must be determined if it is still currently active for that patient. So we're going to go back and we're going to look at these and we're going to look to make sure they were coded correctly. So in item I-2300, UTI has some specific coding criteria, and you're not to use that in active 7-day look-back period. So please refer to the specific coding instructions for item I-2300 for UTI specifically. All right. So look back. I've thrown that word out a few times, and I just want to help define that. Just a little bit more about active diagnoses and the identified issues. So we've seen this before, but once again, remember, active diagnoses are diagnoses that have a direct relationship to the resident's current functional, cognitive, or mood and behavior status, or medical treatments, nursing monitoring, or risk of death during the last 7-day look-back period. So remember, you do not include conditions that have been resolved or do not affect the resident's current status, or do not drive the resident's plan of care during the 7-day look-back period, as those would be considered inactive diagnoses. So check the following information sources in the medical record in the last 7 days to identify active or active diagnoses. You're going to want to look at transfer documents. You're going to want to look at your physician progress notes, want to look at some recent history, history and physicals, recent discharge summaries, any nursing assessments or nursing care plans, look at your medication sheets, doctor's orders, consults, official diagnostic reports, and any other sources that are available. So just to kind of sum up these look-back periods as they're defined, the diagnosis identification look-back is a 60-day look-back period. So physician documented diagnoses in the last 60 days that have a direct relationship to the resident's current functional status, cognitive, mood or behavior, medical treatments, etc., or risk of death during the 7-day look-back period. So some other definitions under here: functional limitations, loss of range of motion, contractures, muscle weakness, fatigue, decreased ability to perform ADLs, and even paralysis. And then nursing monitoring. These are all terms that I've kind of thrown out throughout this, and I just want to make sure I'm defining these for you. Nursing monitoring includes clinical monitoring by a licensed nurse. So like serial blood pressure evaluations, medical management, etc., things like that. Okay. So as we move on, and and we talk about, again, the active diagnoses in the last couple of days. I've kind of covered all of this in speaking about the last slide. I just kind of got my cart before my horse here. But remember, when you're including or excluding your active diagnosis, you do not want to include anything that's a resolved condition, conditions that don't affect the current status, or conditions that don't drive the overall plan of care. All right, so at this time, we're going to move into some review of some actual documentation. In the interest of time, I'm going to pull a few things up. And Jennifer, can you see that I have a PDF file and a Word document file up?
Yes, I can.
Okay, perfect. So if you're following along with the slide deck, I'm just showing some examples on the screen. And this is the documentation review for everyone to follow along with. So for privacy purposes, and to not risk accidentally giving out any PHI or PII, I'm just going to show you some documentation on the screen. So I've taken some notes over here, and that's what the right-hand side of the screen on this Word document has. So when we do a medical review, and when we're reviewing Section I, there's a few things that we have to go through. We have to go through and verify the active diagnosis that is coded. And then I've highlighted on this one those drivers when we looked at that Briggs sample that were actually in green. And so if any of these are marked, we're going to go through and look in the documentation to where we're going to find this. So in this case, we're going to scroll back up. And this patient was marked as having medically complex conditions, and the diagnosis code listed was other and unspecified lack of coordination. So as we look through some of the physician documented information, we can find that this patient was actually admitted for a fall after taking too much oxycodone and melatonin. So she was also found to have aspiration pneumonia at that time. And she was in the hospital and being treated with antibiotics. So there was a few pieces of documentation that we pulled from that were physician documented to kind of help support this. Another was in the swing bed attestation. The reason for admission documented by the physician was frequent falls and generalized weakness. We also have some information in the history of present illness documented by the physician that just re-summarizes that, that pain or the falls were caused by too much oxycodone, melatonin. The patient was actually given Narcan. The patient had some aspiration pneumonia, IV fluids, etc. As well as in the plan. So then we're going to go on and we're going to look at those active diagnoses within the last 7 days that are documented. And I'm just going to focus on these drivers of Medicare payment ones for right now. So there's no documented ulcerative colitis, Crohn's, IBD, no multiple drug organisms. As we scroll down, you can see there's no documentation of pneumonia, but we've noted several times up here that this patient does have some aspiration pneumonia. So it was not indicated on the MDS. I'm misspelling that, I'll fix right now as you're watching. But it is indicated as active in the documentation. So as we scroll on and look at some of the other things, no septicemia, wound infection, diabetes mellitus, aphasia, cerebral palsy, etc. And we get down to CVA or stroke. We do have an indication mark that there is CVA stroke that has occurred in the last 7 days. The documentation supports there was a head injury in July of 2024, and this dates of service, I believe, was November. So the documentation did support head injury. CT scan from the hospital did not support any type of new stroke, CVA, TIA. It does not support any kind of new bleed, any type of traumatic brain injury. And here's the radiology information from the hospital. And here is the information of when these were noted to occur. So we had some subdural hematoma, post-traumatic, some hemorrhage, etc. And these were back again in July of 2023. But the indications from 11 of 23 do not show that. There is some orders for some aspirin, so 81 milligram aspirin, because the patient does have a history of TIA and cerebral infarction. All right. So again, we can kind of follow that along as well. So as we scroll on, looking at the other indicators on Medicare, there's no to quadriplegia, MS, Parkinson's, but yes to malnutrition is marked. But the documentation didn't support this either. So as we look at the documentation, and I know it's kind of hard for you to read, but I'll just read it for you. Here is indication that resident has no decrease in food intake in the last 3 months, no weight loss in the last 3 months. The resident has a BMI of 23 or greater. Their mini nutrition score is actually a 12. And a 12 to 14 is normal nutritional status. So under some of their swallowing disorder assessment, has factors indicating risk for malnutrition, which must be confirmed by the physician, is not even marked. And then again, in the risk for malnutrition, none of this is marked. So as we go back and we look at the rest of the MDS and the things that were marked, there is also a yes for asthma, COPD, chronic lung disease. And we do know that this patient is receiving some treatments via incentive spirometer twice a day for that pulmonary atelectasis, to optimize their lung infection and optimize their cough mechanism. And that was for post-hospitalization pneumonia. And then we do have some information on the unresolved pneumonia and information that was documented by the physician extender, and some treatments of that pneumonia, etc. But nothing really in the form of COPD asthma. Chronic lung disease could be, you know, if God, I'm losing my words. Pneumonia actually becomes chronic. It may turn into a chronic lung disease or a COPD. So then that would make sense. So as you can see, as a result of I changes, pneumonia would need to be changed from a no to a yes because it is an active diagnosis. Malnutrition would be changed from a yes to a no, as the documentation doesn't support and there's no risk even noted in any of the nutritional notes. And malnutrition, as we all know, is a big one that is going to affect coding. So really the purpose of this was just to show you how we go through and we looked at all your documentation and everything that we can find that physician has documented active disease on. We verify that versus other parts of your documentation in an attempt to recreate your MDS and to make sure that it was entered and entered correctly. So with that, we got a few more minutes, and I'm just going to recap what we've gone over. So a lot of information today. We learned about the identified issues. Whoops, this should be section I of the MDS. I'm so sorry. That can lead to the SNF claim being recoded. We went over issues that were identified that can help you help your physician to make sure you're capturing diagnoses correctly. And we can do that in the form of a physician query to get that additional information that we may not have. As billers and coders, please don't guess and please don't assume. If it is not documented by the physician and accurately coded, it's not your responsibility to guess. And if you are a nurse coordinator doing the actual MDSs, please make sure what you're capturing is correctly and it is within the look back time period. So at this time, I'm not seeing that we have any questions in the queue. All right, I'm going to take a quick peek at the chat, and I do not see anything that has come into the chat. So on behalf of myself, Jennifer and Rachel, as well as all of Provider Outreach and Education and our Medical Review Department, we want to thank you for your participation in today's event. So this concludes our webinar, and you may now disconnect.